Okay. You guys see the first slide? And that's it, pretty much?
Yes.
Okay, I just want to get a highlighter and make sure you can see that as well.
Yes.
There we go. You can see the highlighter. Great. So I'm going to speak to you on a biologic approach to frozen shoulder. I say hydrodilation. Some people say hydrodilatation with PRP and concentrated plasma proteins. My only disclosure is I am on the clinical advisory board for EMSITE. And a little bit about my career. I started, after medical school and residency, I stayed in Seattle at Swedish for my sports medicine fellowship, and then worked at University of Washington for 5 years before joining Walter Sussman out here in Boston at Boston Sports and Biologics. Family just needed to be a little closer to home. So the outline for this talk, we'll introduce our patient, discuss some background on frozen shoulder, which may seem familiar to any of you who've watched my lecture that I gave to the AMSSM, which is on YouTube a few years ago. So some of these intro slides will seem familiar, but I'm not going as into detail on the pathophysiology of frozen shoulder in this lecture. We'll review some of the recent evidence on orthobiologics for frozen shoulder, and then show you how we do hydrodilations using PRP and protein-rich plasma. So our patient is a 45-year-old male referred from a local orthopedic surgeon for treatment. He has no history of diabetes or thyroid disorder, no predisposing factors aside from that he's in his 40s. Symptoms began about 6 months ago, and his MRI did show a labral tear, some age-appropriate osteoarthritis and thickening of the coracohumeral ligament. Some of the terms that I'm going to be using will refer to these anatomic structures. So for those who aren't familiar with them, the rotator cuff interval is the essentially combination of the biceps tendon sitting between the supraspinatus and subscapularis, and the ligaments which surround and hold that biceps tendon in place, including the coracohumeral ligament and the superior glenohumeral ligament. So frozen shoulder, this is very brief, and I go into more detail in my other lecture, but it's this insidious onset of shoulder pain, typically insidious, although can be after an injury, and loss of range of motion that affects about 1 to 5% of the population. Now, predisposing factors, the most common ones are diabetes, hyperthyroidism, and just a female gender between the ages of 40 and 60. There is, this is an inflammatory and fibroproliferative disease, and there seems to be some possible autoimmune component to it as well. If you look at the textbooks, they'll usually tell you that it lasts about a year to 2 years. And while that might be true for most, it's not the case for many patients. So the freezing stage is painful and lasts between 2 to 9 months. Frozen, again, can be between 4 and 12 months with limited range of motion. And then the thawing recovery phase can be the longest and sometimes last over, up to 2 years. There are some patients in the literature, still reporting symptoms 6 years out, and I've seen those patients as well. This is the standard, treatment of frozen shoulder, depending on what stage you're in. But our question is, where do orthobiologics fit into this treatment algorithm, if anywhere? So to quickly touch on physical therapy, this has been shown to be beneficial, but mostly or more beneficial if done after a corticosteroid injection, and particularly after a hydrodilation. So speaking of steroid injections, those have been the standard of care for this diagnosis. One of the few diagnoses, I think, in sports or orthopedic medicine that still actually has evidence to support a steroid injection. But we want to get a steroid injection into the glenohumeral joint as early as possible, which is difficult to do, especially in the first 3 months when the diagnosis is not clear and it's presenting like a rotator cuff injury or subacromial impingement or proximal biceps tendonitis. There's really, not much clarity in those initial couple of months until range of motion begins to be lost. So there's evidence that, if you put steroid without a hydrodilation, you'll get some improvement, but you're not really going to affect the range of motion that much. So this was a paper we wrote a few years ago, probably 3 years ago now, where we looked at all the evidence out there. And essentially, there are a lot of studies that show cortisone plus hydrodilation will outperform corticosteroid alone. And there are a lot of technique factors that go into this. So image-guided glenohumeral joint injections were more effective. The injection approach, there are a lot of ways to get into the glenohumeral joint, posteriorly, anteriorly, or via the rotator cuff interval. The rotator cuff interval is shown to give you the best, fastest, and greatest improvements in pain, range of motion, and function. Some people think that this is because we're injecting the steroid around the coracohumeral ligament, and we might be getting more effect on the main ligament that is affecting range of motion. What about the volume? So a lot of doctors out there like to push as much volume as possible. Either they don't know they're rupturing the capsule or they're intended to, but studies would show that leaving the capsule intact is actually a better way to do it. And the average capsule rupture occurs usually around 32 cc's. And so a sufficient volume from some studies has been indicated to be between 25 and 29 milliliters. And those were using pressure monitors to intentionally rupture capsules. So a few years ago, we advocated that the hydrodilation should be performed with ultrasound guidance via the rotator cuff interval to slowly inject a volume of 25 to 30 ml. Now, you can get good outcomes with the other ways, but if you're trying to get the best possible outcome, that was our conclusion. So the technique for that was, find the rotator cuff interval under ultrasound. To do that, you can start at the biceps tendon and then obliquely rotate your probe laterally and superiorly until you find the biceps tendon between the supraspinatus. You can also find the coracohumeral ligament in long axis if you want, but you don't necessarily need to do that for this procedure. And then to inject at this interval, this is really where you want to come in. So from lateral to this ellipse of the biceps tendon sitting underneath the coracohumeral ligament, SGHL wrapping around with your bevel down so that you're not, if you are going to advance too far almost into the biceps tendon, you're more likely to kind of push that tendon away than to pierce it. This was what we used for those standard hydrodilation. So a lot of lidocaine, some ropivacaine, and then and Kenalog, and then enough saline to get you to that 25 to 30 cc mark. And we would do it in this order. Prioritize getting the lidocaine and steroid in there first in case they're so tight that you can't get the rest in. You can always confirm that dilation by looking at the capsule afterwards and making sure that it is distended and not ruptured. Afterwards, we do a manipulation. Now, there are various manipulations you can do, but there are studies out there that support greater improvements in range of motion if you're doing this after a dilation. And I do Spencer's just because that's what my mentors were doing when I was in fellowship. Now, if that doesn't work, then patients are going on to manipulations under anesthesia, but there are a lot more risks with that procedure, or an anterior capsular release. These are for your really chronic patients where nothing else is working. So back to biologics, and we did touch on this a few years ago, but there have been some new studies that have added to this list, and most recently, a meta-analysis by Zhu in 2026, which looked at 13 studies, 13 randomized controlled studies that compared PRP to steroid and found comparable efficacy in months 1 through 3, but PRP demonstrating improvements in pain function and range of motion at 6 months. Now, I would say actually steroid probably, it may not have been significantly better, but steroid did outperform most of these things in the short term. So here we can see that the DASH scores, the functional scores, favored corticosteroid at 1 month, but they increasingly favor PRP at 3 and 6 months. VAS pain scores favored corticosteroid again, slightly at 1 month, and then increasingly favored PRP at 3 and 6. And range of motion in all planes favored platelet-rich plasma. So these kind of studies surprised me when I first read them a few years ago because I did not understand the mechanism at all. I thought this is an inflammatory fibroproliferative process. How is PRP going to help more than steroid? And so I wasn't doing biologic injections for frozen shoulder 3 years ago. And only in really the last year have I started combining PRP with hydrodilations. So there still currently are no studies looking at the combination of PRP and hydrodilation. Theoretically, in my opinion, I think the hydrodilation is still necessary to just kind of stretch the capsule, provide disruption and volume expansion. But the PRP, according to these studies, now they're not using dilation, but PRP does seem to be outperforming steroid. So somehow it's affecting that inflammatory and fibrotic pathology. And Sina will get a little more into that after I'm done speaking. So if we're going to use PRP and a biologic in this hydrodilation, what do we need to consider? And so what should the dose be? Should we be using platelet-rich plasma or poor plasma or both? A2M, what volume? Leukocyte-rich, poor, monocyte-rich? How can we adjust our technique to use less anesthetic? Should we be doing a nerve block? Previously, I did not do nerve blocks. I think with the amount of anesthetic I was using, it wasn't needed. And then should we still be doing the manipulation? So these are the things I would think about. Now, we don't have great data on glenohumeral joints because the knees have been the primary focus. But Berrigan and Bansal have shown in their studies that it seems to be, we know there's a dose threshold for platelets now for the knee. And if you're using less than 5.5 billion, you're probably wasting your time and the patient's money. And ideally, we might want to be getting up closer to 10 billion platelets. Those are the studies that have shown an actual chondroprotective effect on joints. So when we wrote our AAP PM&R guidance statement for NEOA, we recommended a minimum of 10 billion platelets. That being said, there are no specific dosing guidelines for the glenohumeral joint. It's a similarly sized joint, though, so we're kind of using that data to apply in this case. The math, for those of you who haven't seen this slide before, this is important because if you're not measuring your platelets, this kind of shows you that you need to be using at least a 60 ml kit if you're injecting a large joint. So a normal platelet count can be anywhere from 150 to 450,000 platelets per microliter. And the average kits out there get a platelet yield of about 70%. Now the kit we're using, the pure supraphysiologic M-site kit, that report in the white papers gets anywhere from 90 to 97% yield. And I think we get about 85 to 95% most of the time in clinic. So it's a very high yield kit. When you do a blood draw, that's going to be your other variable. How much blood are you taking? So if you multiply your blood draw times your normal platelet count times your yield, a 10 ml draw is going to get you somewhere between 1 and 3 billion platelets. Not enough for any large joint. 30 ml, half of your injections are going to be subtherapeutic. So if you're not measuring, 50% of your patients aren't going to get better, and you're not going to know why. And even with the 60 ml draw, you're not going to get that chondroprotective effect of over 10 billion in about a third of your patients. So I would say a 120 cc kit is what you really want if you're not measuring. And ideally, you're measuring because then you can decide to treat multiple joints if you need to. Alpha-2 macroglobulin, we've talked about this in the prior lecture I gave, but it's a serum protease inhibitor. So it's suppressing enzymes that are involved in the pathogenesis of osteoarthritis. It's also blocking IL-1 beta and reducing inflammation. We don't have many clinical trials on it yet, but from our data, we do see people getting better faster with less pain in that first month. So comparing, our first setup to a hydrodilation to our biologic setup, we're getting rid of a lot of that anesthetic. We are using a nerve block now so that we don't have to use as much anesthetic. And we are substituting in the PRP and protein concentrated plasma for our saline and for our Kenalog. Now, I'm still also trying to figure out what the right ratio is here. How high can I go on PRP and protein concentrated plasma, and how low can I go on anesthetic and still have a tolerable procedure? So, this might change over the next few years, but this is what I'm using right now about. And then in that first syringe here, the first 5 mLs of lidocaine. So I have a 6 ml here, or sorry, I've got my nerve block, I've got ropivacaine, and I have a 5 ml of lidocaine. Some of that 5 ml of lidocaine is going to go into the deltoid, some acromial bursa as well. And now I'm going to just kind of fast forward through this video of the procedure and try to hit on the pertinent parts. So I'll turn the volume off. But like I said, we have a 45-year-old guy. And when he came in, his external range was, I think this is a post-procedure video, but was about 10 degrees of external rotation. The first thing we need to do, okay, here we go. Obviously, is get somebody sterile, but we're going to do our suprascapular nerve block. And so I usually do this with the patient sitting. You can do it with them lying on their side as well, but this is just a pretty simple way to do it. Sorry, guys. I'm going to get rid of the highlighter because I think that is getting in my way. Yeah. Okay. So suprascapular nerve block, you look for the suprascapular notch at the superior aspect of the scapula. I use a curvilinear probe for this because it's a little bit steep of an angle with your needle, so you can see it coming down from the upper right-hand corner of the screen a little bit more easily. And then you're injecting at the suprascapular notch. Once that's done, we're going to lie our patient supine. So now our patient is supine, and this is the angle. It's kind of oblique and pointed down towards the patient's contralateral hip. The gain on this image is it didn't look like this in real life. I don't know, something about the video really increases the gain, but you can see that the biceps tendon is at this short axis oblique angle, and we're going to be coming in from the right side of the screen with our needle. The other key points to this is you really want that left like to be, because the shoulder's frozen, it's going to be harder to get to that biceps tendon. So first thing I'm going to inject is the anesthetic. And I'm going to put some in the deltoid. I'm going to put some in the bursa. And then I'm going to get down, just like I showed on our past videos, to that coracohumeral ligament and biceps tendon interface. Now, you should not see a large collection of fluid expand in this area. You might see a little bit like we're seeing here, but it should stop getting bigger as it flows proximally and distally up and down the biceps tendon. And there are some studies showing, I think that's the first 6 to 7 cc's you inject are going to be stay within that kind of distal biceps tendon. So you need more than that to get into the glenohumeral joint. And then I've switched my anesthetic here. This is also not, as you just saw me looking straight across his body, this is not the setup I would use if I was doing this. I'm set up with the ultrasound at his right shoulder. Normally I put the ultrasound at his right hip, so I'm looking kind of straight down the barrel, straight at the target. But this was just for the filming purposes. So before I get to the true hydrodilation after we put the anesthetic in. I'm letting that anesthetic take effect because I'm going to use a higher gauge needle. I'm going to put an 18 gauge needle in there now. Sorry, this keeps doing that. I'm going to put an 18 gauge needle in, and that's because the protein concentrated plasma, or the A2M, is usually too thick to push through a 25 gauge needle like I was just using. So you'll see now we're going to get our 18 gauge needle out and our PRP. I'm also probably saying here we need to clear any air at the top of the needle when we're dealing with really small targets. And this is a finicky target. The biceps tendon in this procedure, you can lose it very easily if you're not right in line from the get-go, because you can't wag back and forth to try to find your needle. If you're off track and you wag your needle to the left or right, the anisotropy on that biceps tendon is going to change, and then it's going to look just like the supraspinatus and subscap and ligament around it. So you really have to have the right track from the beginning. You see I'm rotating now 180 degrees. So my bevel was initially up to go through the ligament. Now my bevel's down. And as I'm injecting this, I'm not injecting quickly. If I just try to push 11 cc's in there fast through an 18 gauge needle, I'll probably rupture the capsule. So I'm pushing, a cc at a time and seeing how it feels as it pushes back on my thumb. And eventually I'm going to get to a point where I can't, and I'm checking to make sure I have enough that needle is on tight there, because I've definitely had a needle blow up in my face before because I'm pushing so hard that wasn't attached tight enough. Fortunately, that was, I think, when I was doing steroid and not PRP. I'm still injecting. I'm going slowly. Now I finally finished putting the PRP in. So that process looks like it took about 2 minutes. And now I have my A2M. And I didn't remove the needle. I just changed the syringe. And you can see my hand's almost shaking a little bit as I'm pushing this in. So there is some good pressure pushing back on me. But I do want to get to that 25 cc if I can. But if I get to a point where it's really a hard stop and I can't get any more fluid in, I'm going to stop before I rupture the capsule. And that kind of comes with experience. You can kind of tell when you can't get any more in there. And I think we get to a point where we get all of this except for 1 or 2 cc's. Yeah, the last 1 or 2 cc's we couldn't get in. So now we just let him sit. We let that, and we confirm the capsular distension. That's what we're doing there at the anterior recess. And then we let that sit for about 10 or 15 minutes because I want the anesthetic that's in there and the nerve block to take greater effect before I move on to Spencer's technique. And I'm not a DO, so I probably do some things wrong with the Spencer's technique. There's some things I like about it and some things I don't. One thing I don't like is it doesn't really have a particular external rotation stretch in it, which I'm surprised by because, in frozen shoulder, that's the main loss of range of motion typically. And so that's really what patients want to get back. So I add that last, just a supine external rotation stretch when putting them in 90 degrees of abduction. And this whole process takes me probably another 10 minutes. There's circumduction with traction, circumduction with pressure. There's, deltoid traction. I'm also using muscle energy technique in a lot of these positions. So I'm having them resist at that end range and activate their muscles. But, this is now post procedure, and we took them from about 10 degrees to 70 immediately. So these were my takeaways 2 years ago when I gave this lecture. I said that you want to get corticosteroid into the joint as early as possible. If there's a loss of range of motion, then you want to add a hydrodilation. And platelet-rich plasma is second line due to the cost, but maybe it shouldn't be. The manipulation under anesthesia and capsular releases were last resorts. So in 2026, how would I change this? Unfortunately, costs are real and they're real for patients. So this is kind of the ideal scenario. But I think with the studies that continue to support PRP as being a better option in all, function, range of motion, and pain, this is a disease that can last for 2 to 4 years. In lots of patients, we should be doing a treatment that can last longer than 3 months. So I would, if it's an option, advise intra-articular PRP as early as possible. If there's loss of range of motion, then we should be doing PRP plus the hydrodilation. And then if the cost is prohibitive, the corticosteroid plus hydrodilation. The last resorts are still the last resorts, and those are my references.
All right, great. Thank you so much, Dr. Latzka. We already have a quick question. We can just slot this in before the official. Yeah, so there's a question is, any tips on doing the procedure with just PRP if there's no access to A2M yet?
Yeah, I think definitely. So you don't have to have A2M to do this procedure. You could just use platelet poor plasma as your fluid to distend the joint. And you're not doing harm with that. And you could also, you could just use PRP and saline probably as well. But I think if you have platelet poor plasma, you might as well use it. We know that platelet poor plasma has some benefit. We know that it has. We've seen studies from Ryan Cruz and Robbie Bowers out of Emory in Iowa showing benefits for muscle injuries with platelet poor plasma. So I think I would use that as my fluid to distend the joint if I didn't have the A2M or the protein rich filter available.
Okay, sounds good. And just also very quickly, is it leukocyte poor or leukocyte rich PRP?
So that's a good question. We have kind of shied. If you go back 6 years, intra-articular joints were the favor was to do leukocyte poor. But now with all of the data coming out showing the priority should be the dose. Now, I think we've moved more towards having a leukocyte-rich product if that means we're going to get the platelet dose that we need. So most of ours are probably more leukocyte-rich than poor. But one of the nice things about using the Aspiridome kit, you can be a little more specific with exactly how much of that buffy coat you're taking, and you can even do leukocyte rich, monocyte rich, leukocyte poor, and so for a lot of our joints, we're kind of trying to do monocyte rich now. For this one, I'm going to let Sina talk a little bit more about why or how leukocytes can have a unique effect in this pathophysiology.